Morning, everybody. It's a pleasure to be here today in Vadodara. It's always a pleasure to come back to Gujarat year after year and be part of this meeting. And I think today my topic is more talking about pre-diabetes. And it kind of follows what Amit has just said in his talk, that we need to look at more diagnosis of our patients through various ways, whether it is by awareness, whether it's by opportunistic testings, whether we go out in the community and test. Why are we doing all these things? Because we want to see that we pick up our patients early and can we set them on the track for a reversal. Reversal, I don't mean by diabetes reversal, but what I mean to say is that every patient whom we diagnose early and intervene, we are going to bring their A1Cs down so that future complications can be prevented. So if you have patients with pre-diabetes, can we prevent the conversion to diabetes? If you have patients with diabetes, can we prevent their progression to complications? And if they do have complications, then can we prevent end organ failure? So I'm going to look at the other end of the spectrum to say that if people have pre-diabetes, then what should we do about this population of people who are just waiting and round the corner to become diabetics? And once we know that diabetes starts, over diabetes starts, then the problem all starts getting up. So what is the burden of pre-diabetes that we see globally as well as in our own country? So some of the global statistics are, of course, that in US, we have almost about 96 million people with pre-diabetes. In Latin America, about 9.8%. And in Brazil and Latin America, about 22%. So that's fairly high that we see down that side. And we know that over a period of time, these numbers keep changing. So if you look at every IDF atlas, and you see the current atlas also, we see that the trajectory to diabetes occurrences is only going up exponentially, whether it's pre-diabetes or diabetes. But let's look at what are the India statistics realistically. And this is the paper from ICMR in DAP, where we can see that we have almost about 136 million people with pre-diabetes who are just waiting to get converted to diabetes. And that's almost to the tune of about 13 to 14% of our population, which above the age of 18 years, which has pre-diabetes. Now, with the same sort of paper, we can break it down country-wise and see the occurrences all across. And you can see that you see a spectrum all across the country, right from 6% to 14.7% in different states. So obviously, there is not one sort of strategy that is going to be applicable to all across. But yes, the principles of change remain the same. But we need to do more in states which tend to have a high prevalence of pre-diabetes. Because if we intervene at this point of time, the overall diabetes burden across the country is going to make a change. Now, why have we really sort of had a lot of problems in defining pre-diabetes? So if you look at different societies, they over a period of time have defined pre-diabetes by different definitions. And you can see the timelines all across from 2001 till date. And I'll just break this down and simplistically for you. So if you look at the different definitions of pre-diabetes, so the ADA defines it as per fasting, post-meal, and HbA1c, and the cutoff points are clearly listed out there. What about WHO? So WHO defines it more by fasting hyperglycemia, and the cutoff points are 110 to 125. And the International Expert Committee defines it by fasting and HbA1c. And again, you have these cutoff points that International Experts Committee only defines it by HbA1c, not by fasting. So you've got 5 different definitions which actually talk about pre-diabetes. Now, where do I have a problem with this? Let's take this individually. And I've taken all these 5 definitions over here to talk about that which are the ones that apply most. So if you look at the prevalence of pre-diabetes by this definition, clearly you can see the prevalence by individually each of these definitions changes. So you don't have one cutoff point which will define all these different definitions to have a universal prevalence across the country. Now let's look at it from another point of view, that if you want to look at what is the baseline occurrences of various micro and macrovascular complications. So if you look at incident diabetes, chronic kidney disease, cardiovascular disease, or all-cause mortality, then each of these definitions specify different cohorts of people, and then it becomes that which other cohort are you really going to aggressively manage in terms of prevention of prediabetes or conversion of prediabetes to diabetes. Another thing, why did this definition of 6.5 come across? And this came from the PIMA Indians from the retinopathy data. We said that at 6.5, you have the infliction of occurrences of retinopathy, and that's how the cutoff point of 6.5 came along. But nobody looked at that what would be the inflection points for other sort of microvascular complications. So if you look at other microvascular complications like other than retinopathy, like neuropathy, nephropathy, all these things, they have different inflection points beyond 6.5. And if you look at the sensitivity and specificity of each of these cutoff points, then they are different. So again, we come back to the point that should 6.5 be the actual reference point for acceptance that this is the point where over diabetes actually occurs. And remember that this definition came from a very small population of PIMA Indians, which was accepted to the fact that if you have 6.5, that's where the trajectory for occurrence of retinopathy takes off. But that's not been shown for all other microvascular complications. To make things more confusing, the IDF has now come out that we should look at 1 hour post-glucose values. And if you have somebody with 1 hour post-glucose values of 155, then it sort of represents that this patient has a higher conversion to type 2 diabetes, micro and macrovascular complications, obstructive sleep apnea, and other problems. And if you have a 1 hour post-glucose value of more than 209, then it is diagnostic of type 2 diabetes. So now you've got a complete different definition that we're really talking about from the IDF. Now, this was also endorsed by RSSD, and we came out with this paper, which some of the studies that have been done by Dr. Mohan and others, which sort of validated this 1 hour cutoff points in the Indian population. And the stand that we really took was that what does 1 hour post-glucose value represent? So it says, if you have somebody with an elevated 1 hour post-glucose value in the Indian population, then it defines a high risk for type 2 diabetes in adults, children, and youth. It also sort of associates worsened metabolic and atherogenic profiles. It identifies the risk for micro and macrovascular complications and mortality, and a host of other complications that are related to high amounts of adiposity, like muscle, hepatic fibrosis, or for that matter, occurrence of obstructive sleep apnea. And there's a whole other reason that I don't want to list and talk about it in want of time, but these were some of the reasons why we endorsed the position of the IDF because of the studies that were done within our own country. The thing is that it boils down that we have a problem that we have limited resources and we have limited, people, the way they spend money. So should everybody be screened for prediabetes given the fact that ethnically we are a high-risk population? So this paper in Diabetology was a very nice paper which said that which are the cohorts of people that we should really screen for prediabetes. And they looked at 4 different scenarios to say that, okay, we just stop using the term prediabetes because the conversion of prediabetes to diabetes occurs in a very small population of people, about 18% of people. So why are we wasting our resources to test a large population of people when only a small population of people are going to get converted from prediabetes to diabetes? The second scenario is, of course, that we continue to use the term prediabetes to indicate an intermediate hyperglycemia, because now that's a new way that we address prediabetes as intermediate hyperglycemia, because this may be an opportunity to sort of have intensive lifestyle measures and maybe be able to reduce the burden of hyperglycemia by about 50%. And we continue to use the term prediabetes so that we sense that urgency that we need to intervene and do something about it. The third scenario was that we lower the diagnostic criteria and everybody becomes a diabetic. Let's not have the term prediabetes at all. Our intent for using prediabetes was for conversion to diabetes. But if you take everybody's diabetes, then what is the endpoint we are looking at is complications. So if you lower the criteria, then maybe we are going to do aggressive intervention for prevention of complications, and you may lower the incidence of all the micro and macrovascular complications so that patients do not suffer from this, and we have started our intervention program early. And the last one is, of course, that you may sort of do a profiling of patients and say, divide them between low risk, mid risk, and high risk, and then look at which are the high risk or mid risk population which actually requires. And you've got signatures of this which can define the mid risk and high risk population, so that we do a very risk specific screening so that we can reduce the burden of diabetes. Now, pre-diabetes, as we are aware about it, starts very early. Now, conventionally, we thought that when the patient presents to us and we look at the glucose profile, we divide them either they're normoglycemic, they are pre-diabetic, or diabetic. But that's not the case. We have immense amount of studies done by wonderful people, Dr. Yagnik and others, which have looked at in utero environment and how the in utero environment, the maternal nutrition, and the rapid growth of the baby, which develops a high amount of adiposity, becomes a front runner for non-communicable diseases at a later point of time. But this study actually says it's all the Whitehall study. They looked at retrospective data and they said that before somebody becomes hyperglycemic, what is the journey to this hyperglycemia? And they found that insulin sensitivity in this population changes almost 14 years before the onset of the disease itself. So we are looking at now a segment of population. You looked at the risk profiles of these people, and you have this set of population which has changed insulin sensitivity. And 5 years before the actual occurrence, you get a sharp decline in the insulin sensitivity, and you see gradually that the sugar profiles tend to go up. The message here is that small changes, if you trend the patients and look at the trends of values, we see sometimes that patients come to us and they have an HbA1c of, let's say, 5.6. They come to us again after 1 year and their HbA1c is 6.1. And they come back to us after maybe 6 months and they say it's 6.5. Now, if you're looking isolated values, you're missing this journey of the patient. And if you look at the trends across, you know that something's going wrong with this patient because it's gradually worsening. Even within the normal range, if you see, there is enough data to show that I'm going to come to that. But here you're looking at even NASH as a precursor for development. So you're looking at glucose values alone. You're looking at, all the markers of NAFL. And you can see that markers of NAFL plus changes in glucose value have an exponentially increased incidence of prediabetes. So whether you look at it from glucose values or from HbA1c values, it remains the same. So that's why we have changed the definition from NAFL to MASL, because it now represents a lot of metabolic dysfunction that tends to occur. And in MASL, people don't die because of liver events. They die because of cardiovascular events. So that's the risk profile they carry with them. And this has been shown also with the type of adipose tissue that people tend to have, which makes them more, tendency to develop hyperglycemia. So now brings the point that if I know that this patient is on a journey and it's trending to become hyperglycemia, then can I have certain signatures which will identify the high-risk population so that we can start, our awareness programs, our interventions much earlier before they develop even pre-diabetes. So we're talking now about primordial prevention of diabetes. And this is an excellent paper in biology which was published in 2020, and they identified these risk markers which has the potential to identify the segment of population that may convert to pre-diabetes. And if you have any of these sort of combinations of factors, the most important of this being high fasting insulin levels and high fasting triglyceride values. These two values have the highest association for conversion to prediabetes. Now, the implications that we need to talk about. While we know what happens to people when there is a continuum of risk, we're looking at patients who convert from pre-diabetes to diabetes, and we can put interventions into place. But we don't know when does this risk profile start? As I said, we've looked at 14 years backwards. And you have to look at these populations to look at which is going to be the high risk. But obviously, the risk never touches the baseline for patients who are destined to become diabetic at a later point of time. And this was very well the old paper by Stephen Fajans, which showed this, that you need to start looking at high-risk populations early. Now, this was also published in JACC, which looked at, the index 1, which is occurrence of cardiovascular events. And they looked at 30 years before and 5 years afterwards. And clearly you can see from the trajectory of all these graphs that patients who developed cardiovascular events had events which identified dysglycemia even 30 years backwards. So we are looking at now, much earlier on in terms of intervention. And this is also seen in the EPIC Norfolk study that within the normal range of HbA1cs, you can easily separate out patients with a high cardiovascular risk to low cardiovascular risk. And even small changes in HbA1c within the normal range would identify a high-risk population. This was seen also in the nurses' health study. You can see here the HbA1cs within the normal range and occurrences of cardiovascular events. And this forest plot clearly shows you in the low side, these are all normal HbA1c values. But as the HbA1c changes to the higher level, you have patients who tend to develop a higher risk for cardiovascular disease. Again, same thing discovered by nurses' health studies that you've got prior to diagnosis, non-diabetic becomes the reference point. And then after diagnosis and diabetes at baseline, you find that the risk tends to exponentially increase. Now, we have a lot of other risk profiles that sort of associate with macrovascular disease. So it's not just glucose control that is important. We need to look at the blood pressures. We need to look at the lipid profiles. We need to look at all these factors which cause an endothelium dysfunction, a proatherogenic profile, and aggressive atherosclerosis that predisposes them to all these endpoints. But what is important, what I talked to you about, was that we have about 18% of our population that actually converts from pre-diabetes to diabetes. So what happens to the rest of the population that does not convert? Does the risk go down for that population of people that does not convert from pre-diabetes to diabetes? And this excellent paper that was published in Diabetology this year precisely looked at this answer, and they showed that even if the patients don't convert and they stay within the pre-diabetic range, they still carry a high cardiovascular risk with them. And you can see clearly that in the forest plot on the side, that every patient with pre-diabetes, whether he converts or not, should be treated as a cardiovascular risk insulin, and all measures to reduce the cardiovascular risk should be instituted very early on. Can we prevent pre-diabetes? And we've got a host of things that we can do over here, right from patient-centered care. And you've got this wheel over here, which comprehensively looks at how we can intervene in the pre-diabetic population and try and bring down the burden of pre-diabetes. But these are some of the screening or diagnostics that we can do. Look at obese population, look at asymptomatic population, start your screening programs much earlier on in the age. We need to look at the glucose values, the glucose tolerance curves, and A1Cs. And some of the high-risk groups that we can obviously look at is BMI more than 35, fasting between 110 and 125, 2 hours, of course, with the pre-diabetic range, and gestational patients with a history of gestational diabetes. These are high-risk cohorts clearly. We have had a number of pharmacotherapies, and we've got prevention trials that have been done with interventions, with different sort of trials that have occurred over a period of time, which shows that if you intervene early, then you can reduce the risk of diabetes against controls out here. So you've got metformin, acarbose, troliglitazone, pioglitazone, rosiglitazone, orlistat, and lorcaserin, and other ones. And then these are some of the landmark trials which have looked at prevention trials. It all works. You do lifestyle intervention, you do drug intervention, they all work. The bottom line is adherence to therapy and sustenance of the efforts. Because the moment you stop all these efforts, all the risk tends to come back. And here's the diagram that tells you all. So if you do no intervention and just let the patient convert from pre-diabetes to diabetes, go to complications, you're getting a rapid loss of beta cell function, mass, due to high glucose values and lipid inflammation, oxidative stress, all these increase the risk factors. Now look at a case where you've got pre-diabetes and you intervene with treatment, diet, and exercise. You reduce the progression with interventions by reducing the glucose value, and the benefits persist as long as the treatment is continued. And then if you have patients which you're doing already diet, exercise, and treatment, and you do aggressive treatment, then probably you may be able to obtain the benefits for a long period of time. What is important is, can I have just 1 minute more? So what is important is, again, to stress to your patients that you need to keep doing all the good work that you do, because that's where all the benefits tend to happen. We have now got cluster-based, yes, we've got type 2 diabetes clusters that we keep talking about. We've got pre-diabetes clusters also that have been now referenced, and this paper was published in Biomedicine in 24. The idea being that which clusters of population have a high risk and which clusters of population have a low risk. Also, which clusters have a high risk for cardiovascular risk. Again, these have been mapped out very clearly, and how should you approach this problem? So I would urge you to read this paper, which really clearly defines the different clusters with risk profiles. Is there a scope for remission of prediabetes, just as we talk about remission of diabetes? Yes. If you lose 7% of the body weight, there is a clear way that you can get remission of prediabetes. And this stems from the fact that if you lose the visceral adipose tissue, you increase the sensitivity, insulin sensitivity, and that may get you to the goals and keep it there. So in conclusion, we have got a lot of algorithms that help you to analyze. Weight loss remains the cornerstone. Intervening early remains the cornerstone. Lifestyle changes do help, and even if they tend to show a worsening, they never touch the baseline. So at the long term, these lifestyle measures still continue to work even when they're followed up over a period of time. This is an algorithm. I'll be happy to share it with you, but in interest of time, I'll just move on. So the clock starts ticking very early. You need to identify your patients. Do not wait for them to develop over diabetes. You need to identify your patients even when they're on the road for development of prediabetes. Today, realistically, it is possible to identify such a population. And if we do that, maybe we'll reduce the burden of diabetes and prediabetes and keep patients away from complications. Thank you very much.